Sir, it's sharp 3 p.m. So with all your due permission, shall we begin with the session for today?
Sure. Thank you very much.
Thank you so much, sir. Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent stalwart who is present here with us for today's session. Well, sir needs no introduction, but it's our great pleasure and honor to introduce him at our platform. He is none other than the very renowned cardiologist, Dr. Ramamurthy Bengi, sir. Sir is MBBS, MD in medicine, DM in cardiology, and interventional cardiologist at Bengi's Heart Care and Fertility Center. With Sir's wonderful experience and with his insights, we are going to talk about the topic for today's session, which is atrial fibrillation. So before moving on to today's session, let us have a brief look on what the topic says. Well, atrial fibrillation is a common cardiac arrhythmia characterized by irregular and rapid heartbeat affecting the heart's upper chamber atria. It can lead to complications like stroke, heart failure, and other cardiovascular issues. We'll be learning more about diagnosis, management involving medication, lifestyle changes, and sometimes procedures to restore normal heart rhythm and treatment with Sir's wonderful insights and knowledge. So now, without any further delay, let us welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Oh, thank you. Thank you very much for your very sweet words. I'm not that great a guy. Okay, I always love to share my little knowledge with my colleagues. I think on the other side, good afternoon to everybody. The topic that has been chosen today is a very common topic. This is what is called as the atrial fibrillation. The most common persistent arrhythmia, irregular manifested as an irregular pulse, is the atrial fibrillation. In fact, in the cardiology classes, we do teach you about how to differentiate supraventricular, ventricular arrhythmias and the like. But in any patient, if you come across in your day-to-day practice and you find an irregular pulse, irregular pulse means two connotations. One is in volume, another is in the rate. Okay, this irregular pulse constitutes invariably when you see the patient on examination by pulse atrial fibrillation. Of course, there are other clinical signs also. The heart rate will be usually more. An average chronic atrial fibrillation heart rate will be between 120 to 130, sometimes like that. And occasionally there are some patients who do manifest with the slow atrial fibrillation with the heart rate somewhere around 60 or 70. Between 70 and 90, you may see it because of the medication. 60, you may see it in cases with a complete heart block and the like, with the structural heart diseases. But invariably, it's about 120 to 130 or sometimes 150 also. The differentiating point is that in examination, you will not be able to see any A wave in the jugular pulse. You will have an irregular pulse examination, that is arterial pulse examination. And the same way, the systolic blood pressure also will be variable. Your Korotko sound when you are trying to auscultate also will be variable. And when you auscultate on the chest, you make out the heart sounds are also variable in intensity. And more than that, what we call it as a pulse apex deficit, which is usually more than about 10 beats per minute, is considered as a sign of atrial fibrillation. This is how we recognize atrial fibrillation. Now, this atrial fibrillation over a period of time for the last few years has become a very important arrhythmia being discussed all over. For the simple reasons, as my introducing person gave it to you in the beginning, the major two issues are that it produces an not only an manifestation like heart failure, angina, chest pain, or something like that, but it also manifests as an embolic episode. Systemic embolism are frequent. Similarly, pulmonary side also are frequent. Some of them go unrecognized. And for this reason, this atrial fibrillation becomes a very important thing. Thirdly, the atrial fibrillation person, one side, and non-atrial fibrillation on the other side, the longevity of this atrial fibrillation patient comes down. The morbidity is high, the mortality is also high, apart from the thromboembolic phenomena. Thirdly, as I said, it can precipitate heart failure and so many things. More than that, slowly over a period of time, we have recognized this arrhythmia can also create a special cardiomyopathy. The LV function becoming poor, what is called as a tachycardia-induced cardiomyopathy is also become recognized. So thus, the manifestations of atrial fibrillation are many. So everybody is concerned to divide these patients in the earlier days. We used to divide them into symptomatic atrial fibrillation, asymptomatic atrial fibrillation. Most of the patients are symptomatic, and the arrhythmias that are being looked into symptoms wise, we have various therapeutic approaches, and which I am going to discuss here. The atrial fibrillation is quite frequent. It is almost affects more than 1% of the population. Over a period of time, the number of individuals above the age of 60, 70 years having an atrial fibrillation has slowly and steadily gone up. You can expect up to 10 people out of the 100 above the age of 80 years will have some amount of atrial fibrillation in their lifetime. It does become considered more like an epidemic. Let me not go into the discussion. Now, the last European Society of Cardiology, there have been a few points that have been discussed. One is that atrial fibrillation is a manifestation of multiple diseases, a heterogeneous population of cardiac diseases. And invariably, up to 1/3 of them will not be able to detect the disease when we call it as a lone atrial fibrillation. But earlier days, about say 10 to 15 years back, the commonest disease entity that we used to see was rheumatic heart disease, followed by cardiomyopathy. Now it has become an ischemic heart diseases are the most common. Apart from that, we have seen there are some so-called lone atrial fibrillations based on the probably genetic ones. And the sleep apnea syndrome is equally important, obesity, metabolic syndrome, chronic obstructive pulmonary diseases, and some of these other diseases have been recognized as the manifestations of the etiological factors for the atrial fibrillations. But in day-to-day practice, still we often see the ischemic heart disease is the commonest one. A few years back, it was being taught that the hypertension is probably the commonest one, but it is not so. Now we do see that more of the time in ischemic heart disease in various manifestations of LV dysfunction, LV aneurysms, and ischemic heart disease documented, both non-documented, are responsible. Underlying diseases like hypertension, hypertensive heart disease, rheumatic valvular disease, and non-rheumatic valvular disease, and cardiomyopathies, including both the dilated cardiomyopathy and hypertrophic cardiomyopathy, are also quite common. In the symptoms wise, let me not go into the discussion. Basically, when the atria is not able to contribute to the cardiac pumping, the manifestations of the atrial fibrillation do manifest because it is becoming irregular. There is no concerted contractility of the atrium. There's a tendency to develop thrombi and thromboembolism. Now, other than understanding the mechanism, basically, we do have various classification. One is, of course, symptomatic atrial fibrillation, asymptomatic atrial fibrillation. We have one what is called the paroxysmal atrial fibrillation. It comes and goes. Sometimes it may be recurrent. And we have a persistent atrial fibrillation and a permanent atrial fibrillation, which persists for more than about 48 hours, and it becomes not terminated and established like that. We have got various things. Now, European society tries to emphasize that this sort of a differentiation is not necessary because whether it is a paroxysmal, persistent, or permanent, all of them have an equal propensity to develop thromboembolism, and it has to be managed with the anticoagulants also. But in a paroxysmal atrial fibrillation, which lasts less than about 24 hours, the earlier days we used to invariably tell to put them on anticoagulants before converting them to the sinus rhythm. That sort of an mind block to put them on anticoagulants is not necessary if it's of a short duration of a paroxysmal atrial fibrillation. But otherwise, all of them, they need to be covered with the anticoagulant therapy also. So this classification is more or less not needed, but is earlier mm, cardiologists used to feel that if the patient has got a short duration atrial fibrillation, then the form of paroxysmal or recently detected persistent variety, there is a chance that they may get converted into sinus rhythm either pharmacologically or electrically, whereas the permanent one doesn't get converted, and we should not think of getting conversion. We should try to do what is called as a rate control rather than the rhythm control. These are all small, minor dissecting points that have been talked about. Let me not go further again into the various classifications I have already told. The evolving therapeutic approach includes basically preventing the thromboembolism. I would like to mention in the beginning, I did make a comment at the beginning. Hemodynamically, atrial fibrillation is a sort of an spectrum, hemodynamic spectrum. Clinically, also it is a spectrum. And what you see as an atrial fibrillation and low atrial fibrillation may be different from a tight mitral stenosis atrial fibrillation, or a patient with an EF of about 30%, or a patient who has got normal EF but at 60% EF. Like that, it is variable from one clinical entity to the other clinical entity. And thus, we have to manage the cases depending upon the hemodynamic subset as well as the underlying heart disease. So here, fundamentally, this whole concept of using a rhythm control beginning by using various pharmacological methods was attributed in order to maintain the atrial boost that is often helpful for improving the cardiac output. But this is not being accepted in the majority, because what happens, there is always a chance of a recurrence once. Second thing is the majority of the cardiac drugs that we're using to do the rhythm control are toxic. And I've seen patients being used. Some of the uh, more toxic group of medicines like amiodarone for a long term, for a chronic atrial fibrillation, producing a spectrum of side effects. That is why the people are who have this concept of bringing back the rhythm as well as possible have got a newer modality other than the medications. Like one is, of course, catheter-based ablation techniques. And in this, there are various ones, RF ablations, that include the multiple foci, creating various linear, scars, and sometimes ablating around the mouths of the pulmonary veins. Sometimes recognizing the focus and ablating the focus, and ablating the AV node and trying to put a pacemaker. So many things are there. I think these are all, let us not discuss these days, because these are the feats of the electrophysiologist. He will tell, but only when to accept this sort of cases for the catheter or other things, let me not. New pharmacological treatments and methodologies are also coming. Sometimes what is called the pill in the pocket methods and other things. Sotalol has emerged as a very important drug. The combination drugs are much more commonly being accepted. The embolic complications in atrial fibrillations are quite common. In fact, almost fourth of 1/3 of the strokes that we see in common day-to-day practice appear to be an embolic stroke. And in fact, we cannot take it lightly for two reasons. One is strokes, they do carry a poor prognosis, they create a disability, And in fact, they are the most common cause of cardiovascular deaths also. And these are some of the reasons we should keep it in mind that we have to make an effort to see that we give the anticoagulants and protect them. More than that, we should understand one part. A disease occurs one time, it always recurs. Similarly, embolism has got a tendency to go on recurring. And this is the reason why we should try to see that the patients are protected by using anticoagulant therapy. We have various preventive thromboembolism and conventional cardiologists. We have been using always a short course in the beginning to cover up with an IV heparin, followed by the oral anticoagulants, a long-term oral anticoagulants therapy, which is being monitored frequently using PT and INRs. And this being questioned for various reasons. One is bleeding risks are more, and it needs a repeated management by using the PT and INRs. And the particularly if the patient is living in a rural area or a semi-urban area, he may not be getting frequent checkups done, and so many things. For example, we used to see earlier rheumatic heart disease patients becoming without, in spite of repeated giving counseling, they would have become pregnant. And there's own problem that the child that is not yet born during that, what is called as warfarin embryopathy, premature deaths, mental retardation, so many things were there. So the newer generation anticoagulants start emerging. And today is the day of newer oral anticoagulants that are being used where there is no need of doing repeatedly in PT and INR. And I will just try to make a small comment on that. And there are, as I said in the beginning, only the clinical subsets are different these days than earlier days. We have more frequent IHDs. IHD subsets are again vary with or without LV dysfunction, triple vessel disease, left main disease, undergoing CABG, undergoing PCA, post PCA management with the atrial fibrillation, and the like. We do go on seeing the patient in them to use a combination of aspirin, and for example, a patient has undergone an aspirin plus clopidogrel or aspirin with something like prasugrel or other medication, dual antiplatelet drugs. When we add a third antiplatelet drug, what third oral anticoagulant we add, what should be the medicine that should be used, how long it should be used. These are all the areas which are like touching on a raw nerve. Let me again not go into the depth of this. Earlier, oral anticoagulants, we used to see that we do always ask them to maintain an INR of 1.6 to 2.5 in patients above the age of 75 years, or those who have atrial fibrillation with less age and are associated manifestations like, the patient needing an because of the wall replacement that has been done, we used to go on a little bit on the more side, it's like 2.5 to 3.5 and the like. Now, the buzzword is that when you are using an antiplatelet, anticoagulants, you should weigh the patient in terms of what is called as a hemorrhagic complication on one side. Another side, you should use that drug which can prevent the clot in the left atrium and prevent the thromboembolic complications. So one is, on one side is you are trying to look at the prevention possibilities with a particular group of drug which has shown efficacy in various trials and as well as clinical examinations. On the other side, you are trying to also select out the patient to see that he is a relatively low risk for the bleeding complications. So in this process, there are so many classifications that have come, what is called as the has blood score, and we have similarly to use the oral anticoagulants to prevent the stroke. We have got various other chart, 2V vascular 2 scores and the like. But anyway, I feel as a clinician, the age of the patient, the sex of the patient, past history of recurrence of thromboembolic phenomena, clinical presentation of thromboembolic phenomena, underlying heart disease. And these are some of the simple factors which can be computed within our brains to make this equivalent of chart 2 square and a possible bleeding risk square by trying to ask them whether they have an chronic GERD problem? Are they taking antiplatelet other drugs? Are they taking any history? There is a history of any bleeding peptic ulcer, chronic abdominal issues, or a cerebrovascular accident earlier, which was a hemorrhagic, something like that. We take on the other side and try to make a rough estimate within ourselves whether the patient has got a high risk for bleeding or a high risk for a thromboembolic episode. Accordingly, we try to target the various anticoagulants. We have various studies in that, FSAC trials, PAP trial, BATAP trial. So many trials have come, and bleeding rate percentage per year, they have tried to look at it. And I'm not going to dwell into these things. Equally, there were a lot of issues in the oral anticoagulant which we were using, that there were a lot of limitations. Hardly about say maybe 2/3 of the patients were reaching the targets. Majority of them, they never reached the targets, up to 10% of the cases, and the subtherapeutic range was about 13. So roughly about 15 plus 13, roughly they were taking in that, probably by giving a repeated knowledge to them that PTA, this titration of the dose is necessary. We could have brought them to the nearer to the level of therapeutic value. So there were some problems of both compliance issue as well as an adequacy issue also in our day-to-day care, with the particularly with the oral anticoagulant that we had, that is warfarin and acetone, like that. So there are questions about an ideal anticoagulant. We not talk about that. The newer ones which we have used is the heparins, fondaparin. These are all being given IV, and we have also got this the major trials, affirm raise and other things. Let me not go into that rate versus rhythm control and all that. So the major issue in managing in atrial fibrillation is don't bother about whether you are treating what subcategory of atrial fibrillation. All of them, they need preventing thromboembolism. Only one factor you should keep it in mind. If the patient is above the age of 80 years, you can put them on only some aspirin or something like that instead of giving powerful anticoagulants, putting them at a risk of having a major bleeding. And to avoid that, various catheter-based methodologies have come. And now in Western countries, they are trying to look at that. This management has become what is called as a multidisciplinary approach. There is a cardiologist, there is a physician, the patient might have come from other field. We have to include them also. Then we have to have an electrophysiologist on our board, and patient relatives, and the expectations of the patients and the expectations of the patient relatives. All of them have to be decided, keeping the various branches in mind. And decision making has become combined, both the patient as well as the doctor. Just seeing the patient one time, taking an ECG, making a diagnosis of atrial fibrillation, prescribing something, and asking him to come back and try to add anticoagulants. And this sort of approach is not correct. We should become more scientific. There is a need that we have, because this is a lifelong treatment, more or less. The decision as to whether it's the not catheter based or non-catheter based has to be done along with the patient's relatives in mind. So it should be a combined effort. Catheter ablation is being practiced more and more. But one should try to look into is that whether the conventional medicines have failed, or the conventional medicines the patient is not ready to take, or the conventional medicines have made a lot of side effects. Are there any associated underlying disease which need to be addressed simultaneously? And above all, patient and patient relatives are accepting for that, then only we should plan for the catheter ablation. So there are something else also, like for example, the use of ACE inhibitors are also being talked about. There are a lot of buzzword is going that there is an ACE inhibitors and ARB drugs. They themselves will prevent the further on recurrence of atrial fibrillation. Again, I'm not going to talk about it. How the angiotensin and angiotensin 2 ACE receptors are responsible in the response to produce a perpetuation of atrial fibrillation. So the clopidogrel, clopidogrel and other drugs that are being used in ischemic heart disease are patients who have got a multiple risk factors or who are undergoing a PCI bypass surgery. That is again a subject which is beyond our discussion today. So in a nutshell, I have tried to do an simplest of the talk today, that is an atrial fibrillation. It is atrial fibrillation of different clinical categories, how to recognize clinically. One more point I just would like to highlight here before I summarize the things is that European Society of Cardiology has recommended never make a diagnosis of atrial fibrillation, though I said that clinical examination will tell you majority of the time in a chronic persistent rhythm disturbance as atrial fibrillation, you have to take an ECG. You have to take a 12-lead ECG or a single channel ECG like a rhythm strip that you have taken. It should be at least for a period of 30 seconds before you conclude that there is a atrial fibrillation, what sort of atrial fibrillation, whether treatment is necessary or not. So after that only you should be able to make out what underlying disease is there, what is the impact of that, what is the LV function that's there, what are the other diseases which need to be attacked, and then whether it can be managed by rhythm control alone or the rate control alone. But today the main object is, main modality, method of treatment is to use the drugs as the first choice, other than the anticoagulants and other agents that we're using. We should try to use an first line, second line, third line drugs, which I am not again trying to dilate them. The drugs that we often use is the first is the beta blockers. Then we try to use along with that calcium channel blockers, particularly either a verapamil or a glitazone. Be careful when we're using a verapamil, it may produce further cardiac depression. So we can use an instead of verapamil, we can use a glitazone. And if these two drugs have failed, now we have newer drugs like sotalol has come up, and profacaron is also there, and class 1 drugs are also being used. And you should use cardron only after having given a thought for all of them. And you should ask a question to yourself whether if I use this drug, how frequently I am going to follow him up, and whether it is going to produce a potential side effect for him. And it should be a very transient usage for as far as the cardron is concerned. Why I am trying to repeatedly talk about this is that cardron today is being used left and right, particularly the ICU setup. The moment you recognize the patient with atrial fibrillation, we do use cardron, and it continues. When it comes for a follow-up, we might have forgotten totally, and this patient might be going on a cardron for a long time. Don't do that. If such situation is there that the patient needs the conversion, okay, have a discussion with the various modalities of service providers and then decide whether he can undergo RF ablation. RF ablation has shown a success rate of almost 60 to 75%. So it should not be taken lightly. Then other modalities also there which I didn't touch upon. For example, a patient with a rheumatic heart disease. He has got a severe calcific mitral valve. He has to undergo surgery. So when he's undergoing an open heart valve replacement, mitral valve replacement, then we ask the surgeons to do a surgical maze procedure. Or you can do it after that once the valve replacement has been done. Like that, we can do many more procedures. So anyway, this is a non-drug management should be always in conjunction with the other specialties. My own experience is that many a times faster control of the rate is achieved by a combination of medicines. Like if you are using an beta blocker along with an titrating dose of diltiazem, or if there is the patient is not an beta blocker, or you are using simultaneously something like a sotalol other medication apart from the that's also a sort of beta blocker. Some of these drugs can be used. Earlier we used to use the digoxin. Some clinicians still use it, probably the third line medication, but it is always better we use it in combination with any of them, and it should be used in a smallest tolerable dose for arrhythmia management. I found out digoxin is much better when there is an atrial fibrillation. The ventricular rate goes on changing very sensitively for slightest of emotions and are exercise related. Then the digoxin also helps in the control of the rate. In any way, the chronic atrial fibrillation, the rate should be kept as much as possible between, say, 90 to 100. Up to 120 heart rate, you can allow for a simple 6-minute walk test to say it's optimally controlled. And in a resting ECG or resting examination, if the heart rate is as much as possible around between 70 to 90, it is better. So this is one of the method of looking at whether these drugs are being controlling the rate properly or not. So this is the shortest talk which I have done, how we choose the drugs and what is the focus that is being given for the antithrombotic, anticoagulant drugs, oral anticoagulants. There are so many, apixaban, rivaroxaban, all of them. I have not discussed that because it becomes too much for the present today's talk. And second is, of course, the control of the rate as much as possible. Select the cases for the rhythm control, either by the drugs, pharmacological conversion, or by electrical conversion, and then subsequently preventing them by RF ablation or the catheter-based technologies. Thank you very much for your patient here.
Thank you so
Hello.
much, sir. Thank you for
Thank you.
your
Thank you very much. I think it's been a very short talk, but a very worthwhile discussion. And IJCP platform. Thank you very much for inviting me.
Thank you so much, sir. We have received few questions, sir. So with all your due permission, we would like to put across those questions for you.
Go ahead, please.
Yeah. So the first question is, what is the impact of pre-injury anticoagulation therapy in the older adult patient experiencing a traumatic brain injury?
I didn't catch it properly. Please go ahead, repeat it.
Yeah, the question is, what is the impact of pre-injury anticoagulation therapy in the older adult patient experiencing a traumatic brain injury?
Okay, well, you mean to say the patient has developed a brain injury about the elderly person having the brain injury, and you want to use an anticoagulant. If there is no atrial fibrillation, there's no need of giving that.
Thank you
Because
so much.
yeah, because in a sinus rhythm, there's no indication. Okay, so you will be able to create a problem in that. Even using a simple drugs like aspirin and clopidogrel, you should be very careful. Leave alone anticoagulants.
Thank you so much, sir. Thank you for answering that question. We will take up the next question that we have received. And the question is, what are the probable side effects of apixaban?
The more commonest side effect is all these drugs is basically, possibility of bleeding, excessive bleeding. It may be intracranial bleeding, it may be GI bleeding, it may be traumatic bleeding. And this is one side of the story. Second side is it is possible that there may be an organ dysfunctions, particularly renal related. And these are some of the things which we should keep in mind. Chronic bleeding may produce an anemia, which is not recognized in the usual follow-ups. And suddenly a patient comes with a little more breathlessness, we start recognizing this. So these are some of the issues that we can come across.
Thank you so much, sir. Thank you for answering that question. We will take up the next question. And the next question is, what is your advice on oral antithrombotics for stroke prevention in non-valvular atrial fibrillation?
Non-valvular atrial fibrillation, again, I'm using nowadays those patients who are already on the regular oral anticoagulant, like the brand that we are using, like acetron or warfarin, I usually ask them to continue them. But I would like to emphasize that there are other drugs also have come. These drugs may be helpful for you, may not be helpful. For example, we do not have scientific knowledge existing today for the rheumatic valvular disease atrial fibrillation. And non-rheumatic valvular atrial fibrillation, we have an evidence. So like that, we should be able to, if they are already continuing and they are comfortable, they can get a frequent PT and INR done. They're staying in city places that can come to the city quite frequently, say once in a month to do the PT INR. We'll ask them to continue the same medicines. But on the other hand, I am for the newly detected ones with or without ischemic heart disease. I have been using nowadays the presently available apixaban I have been using, rivaroxaban I am using. Okay, these are the usual drugs I have been using. I am more comfortable with rivaroxaban and apixaban, less commonly used.
Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their ardent participation that they have shown by being here with us throughout the session and listening to us and putting up their questions to us. So thank you to all of them. And with this, I would like to thank you, sir, for taking out your valuable time and for being here and sharing such wonderful insights with all your efforts upon the presentation. So thank you so much for that, sir. And with
Thank you
this,
very much. Thank you very
yeah,
much. I hope
with
I have
this and
made.
with all your last comment, we would like to conclude the session here for today, sir.
Thank you, ma'am. Thank you very much. I hope I have made it very light and sweet. Thank you.
Yes, yes, absolutely, sir. Thank you so much, sir. So to all the viewers, we are concluding the session here for today. Until next time.